Hey everyone, my name is Onowori Victor. I am a neurology aspirant and I'll be doing the Ching Ching's comprehensive review in clinical neurology. We've done questions 1 to 19, so we'll be doing 20, 21, and 22 today. Let's start with 20. We have a 42-year-old woman with a history of multiple sclerosis who presents with a complaint of recent onset diplopia, especially when she looks to the right. On examination, you find that on right lateral gaze, she has impaired adduction to the left and nystagmus of the abducted eye. Where do you suspect this lesion is localized? So this is actually a very simple question, but it actually needs technical knowledge. So we have a patient who looks to the right, but when she looks to the right, she cannot um, move the left eye to the right, and the right eye that's moving to the right is undergoing um, nystagmus. This is classical for something we call an MLF lesion, a median longitudinal fasciculus lesion, and basically the eye that cannot adduct, adduct is the eye that is affected. So, which eye cannot adduct here? That is her left eye. So, her left eye cannot adduct, and um, that is where we have the MLF lesion. So, the right eye is undergoing nystagmus, but why? So, let us do a little explanation in here. Now, if you decide to move your eye to the right, what happens is that your prefrontal eye field, which is at the contralateral side, so let's assume you want to move your eye to the right, the left prefrontal eye field basically sends information into something we call the PPRF, the pontine paramedian reticular formation. So the left frontal eye field sends information to the right PPRF. The right PPRF then sends information, then activates the abducens nerve on the right. The abducens nerve cranial number 6 on the right then sends information to the lateral rectus on the right, and that pulls the right eye to the right. Right, so it's kind of abducts the eye, the right eye. Now, at the same time, information also passes from the abducens nerve into the MLF on the left, that's the median longitudinal fasciculus on the left. In the MLF, we now have signals reaching the median rectus oculomotor nuclei, and that sends signals to the medial rectus and causes the left eye to move to the right or to adduct. So that complex pathway enables you to have coordinated gaze. Similarly, if you want to look to the left, what happens is that the frontal eye field on the right sends signals to the left pontine paramedian formation on the left, and then when that signal gets in there, it then activates the left abducens nerve. The left abducens nerve then sends signals to the or sends fibers to the lateral rectus on the left and causes the left eye to move to the left, or it causes abduction, while the abducent nerve, the activated abducent nerve also sends signals to the right MLF, and that will then send its own signal to the medial rectus oculomotor nerve subnuclei, and that would in turn send its own signal to the medial rectus on the right, and that will cause the right eye to move to the left, or adduction, adduction of the right eye. Now, if you have a lesion on the MLF, what happens is that the let's assume you have a lesion on the left MLF. So you want to move your eye to the right. The signals come from the left frontal eye field, goes into the PPRF on the right, hits the abducens nerve. From the abducens nerve, it causes the lateral rectus, so move to the right. Now, after moving to the right, then the abducent nerve will also send signals to the MLF. Now that MLF on the left is not working, and that means that the left eye cannot move to the right or cannot adduct. And if that happens, you are actually looking at an object, actually looking at two different objects. So the brain kind of tries to make your left eye to move to the right by sending much more signals. So that will cause hyperstimulation of the abducens nerve, and that will lead to nystagmus on the right because your body is kind of confused as to where you're actually looking into. So that causes the nystagmus. It's important to note that slowing of the adducting eye may actually be a sign of partial lesion to the MLF. And when you have lesions to the MLF, we call it INO, intranuclear ophthalmoplegia. And this can actually be detected on optokinetic nystagmus testing. So it's important to know some variations of the intranuclear ophthalmoplegia. We can have bilateral lesions of the MLF, we call that bilateral internuclear ophthalmoplegia. And what happens is that basically both eyes cannot adduct. So the right eye moves to the right, the left eye moves to the left. And we call that wall-eyed bilateral intranuclear ophthalmoplegia, walled-eye bilateral INO, also known as Webino. It's as if your eyes are looking to two different walls. Now, if you have a lesion to one side, to the ipsilateral abducent nerve, and at the same time you have a lesion to that same MLF, what happens is that you are going to have something we call a one and a half eye. The affected eye will not be able to move in any horizontal direction of gaze, but the unaffected eye will be able to only abduct but will not be able to adduct due to the fact that the medial rectors cannot receive signals from the opposite abducent nerve. So we call that again one and a half syndrome because the affected eye is totally affected, so that's one, while the unaffected eye is affected only partially because it cannot adduct. That's half. Okay, so back to our question. We've said that the adducting eye is the eye that cannot adduct is the eye that is affected. So that would be the left MLF, the left MLF. So number 21, your patient returns 2 weeks later with complaints of diplopia in all directions of gaze. On examination, you find that she now has extropia of both eyes on primary gaze and no voluntary horizontal adduction. Where do you localize her findings to? So this is easy. This patient has bilateral INO. Basically, you have right and left MLF damage. So question 22, 3 months after treatment with pulse corticosteroid therapy and return to normal extraocular function, your patient presents to you again with new ocular complaint. On examination, you'll find that she has no horizontal movement on the right eye, so one eye is gone, and only has abduction of the left eye, so half eye is gone, agitated with nystagmus. Where do you localize these findings? So the part where she has no horizontal movement is affected ipsilaterally. So we have both the MLF and either the PPRF or the abducent nerve taken out. So right abducent and left no, right PPRF no, left PPRF and right MLF no, right abducent and right MLF. That's yes, options D.